orthopedic surgeon and sports medicine physician, and today I'm going in depth on Allen Hurn's injury. Once again, I have to say thank you to all of the returning members of the intern army and to all of the new subscribers for showing me so much love on my Dr. Reacts to NFL Football Injuries video.
We interrupt this program to bring you a special report.
So in my recent video, Dr. Reacts to NFL Football Injuries, I screwed up. Yeah, I made a mistake. I messed up on the first one and I said it was one player getting injured when it was actually Earl Thomas. And I knew it was Earl Thomas, but when I showed the video and reacted to it, I actually reacted to the wrong thing.
Okay, yeah.
But pay attention to the channel because in the near future, I'll be going in depth on that injury to make up for it. So many of you have asked me to react to Allen Hurn's injury. I figured I would do a special bonus video where I react to just that injury alone. But we're gonna go in depth. Let's get it. So this game is on January 5th, 2019. Is the NFC wildcard game between the Dallas Cowboys and the Seattle Seahawks. We are just in the first quarter of the game, and I believe there was 7 minutes and 28 seconds left in this quarter, so we're gonna pick it up right there. Dallas is on offense here, 3rd and 7, 4 receivers, balanced formation. Allen Hurns is the closest receiver to us. 2 steps, quick slant. So he catches the ball, he's got first down now, drops his shoulder, cuts up field, so we can see he collides with the free safety. When the free safety grabs him, it's not really a head-on collision, and the free safety starts to wrap around him as he falls to the ground. Can't really see what's going on, that Allen is kind of rolling around, and he looks to be in obvious distress. So here we have the positive lineman look away sign, okay? And when you see a lineman come down to help you up and then run away looking like this.
Look away! Look away! Oh!
That's usually a bad sign. So now if we look at this from a head-on camera view and we get a slow motion of this, you can see exactly what I'm talking about. So as the free safety tackles Allen, you can see that he kind of rolls down to his left-hand side. And he wants to make sure that he completes the tackle, so he holds on to Allen as he's going down. And Allen, who's trying to get some of those precious yards after catch, keeps motoring upfield. He keeps his feet moving, he keeps running. So as he's running, and as the free safety starts to roll down his body, there comes a point at which Allen plants his left foot on the ground, and then the free safety rolls down onto his leg. So now the foot is planted on the ground. From this point out, only bad things are gonna happen. For those of you who've watched my other videos, you know this off by heart. Bones are very strong in compression, but they are crap in rotation. Here is a prime example. The leg is internally rotated away from the planted foot. And if you watch this slow-mo replay, you can see the exact point at which the bone says, I have had enough, uncle, I give up. The leg cannot tolerate any more external rotation, and eventually the fibula breaks. So now we have another heads-up view, but from a slightly different angle, and we can watch this again in slow motion. From the moment that the foot is planted on the ground, that it starts to externally rotate on the leg, and as the leg internally rotates away from that planted foot, you can see that the inside part of the ankle touches the ground, and then fibula gives up, which occurs right about now, and the rest is history. So they quickly get out the athletic trainer and the medical staff because this is a bad injury and they recognize this is something he is not walking this off, and this is something that is going to require medical attention. So they get the backboard, they try to get him off the field in an expeditious fashion as possible. So as we've seen with some of these other players, such as Alex Smith, which happened in November, sometimes these injuries can be open, or what people commonly refer to as compound. So at this point, he's still got his shoes and socks on, so they don't know whether this is an open or a closed injury.
We won't show it again, but it was left ankle and just ugly.
In a general sense, we typically like to have dislocations reduced, which means we put them back into joint within 6 hours. That doesn't mean that we necessarily have to treat the fracture within that time frame, but we like to have the dislocation reduced within 6 hours to protect the cartilage on the joint surfaces. If this is a compound or an open fracture, then we generally do like to fix that within 6 to 8 hours to avoid complications such as what has happened with Alex Smith. We want to make sure that we don't have infection setting in, so we want to get those open injuries closed as soon as possible. For closed fractures, or fractures in other words where the skin is not broken, then there is not necessarily that urgency to do so, but we do want to reduce the dislocation in as quick a fashion as possible. The immediate or on-field treatment of these athletes really kind of depends on the staff that is present and their knowledge and skill set.
Gruesome left lower leg injury.
In most cases, these athletes are probably going to be splinted in the malreduced position. In other words, if their foot is on sideways, because people just generally don't know what the injury is without an x-ray, they are typically going to be splinted in the position in which the extremity is at the time that it was injured. So in other words, if your foot is on 180 degrees in the opposite direction to where it's supposed to be, or at some kind of funny angle, they are going to put a splint on in that position so that it doesn't move. The general reasoning behind this is because they do not want to worsen any injury that is present. Now, obviously, in this setting, this being the National Football League, the NFL, these guys, of course, are gonna have some of the best, most qualified sports orthopedic surgeons in the country. So these surgeons are obviously going to have an idea of whether this is something that they can reduce on the field before splinting and sending off to the hospital, or whether they need to wait and splint in the malreduced position and ship off as quickly as possible. But either way, he needs to go to the hospital and this needs to be treated. So we can see them carting him off here and getting him shipped off to the hospital, and obviously the rest of the players on both teams, the Cowboys and the Seahawks, are like really concerned because this is a bad injury and nobody wants to see this. There was no information specifically that said what injuries he had, but I'll tell you what is most likely. And there was a social media post, which I'll put up right here, which said that he had an injury of both his ankle and his knee. And you can see that he was rolled up on the ankle, and obviously there was some kind of fracture that occurred at the level of the ankle. So it's most likely that he suffered an ankle fracture dislocation. However, they said that he also had his knee injured. There wasn't really anything that occurred in his knee. So what's going on here? There is a particular type of fracture which is called a MAISONNEUVE fracture. And I'll show the spelling of that. And it's a particular type of fracture that occurs where force is transferred up the interosseous membrane. That is a tissue that lies in between the tibia and the fibula, which helps to keep those bones together. This is a prop. See my prop here? This is an anatomic model of the tibia, the fibula, and the ankle. Tibia, F for fibula, and there's the talus, part of the ankle. Let's recap. Sometimes the force of the fracture is so strong at the level of the ankle that the force can be transmitted up between the two bones when the ankle is displaced or out of position or fractured. The force can be transmitted up through these two bones and then out the fibula at a higher level. You can end up with something like this. A fibula fracture higher up, even though the original injury occurred at this level. That's called a MAISONNEUVE fracture. Dislocation or fracture here with another fracture at a higher level. And I think that's what he had, because if you read the social media post, it says that he had a ankle fracture, dislocation, and then an injury of the knee. And this usually occurs higher up near the knee, so that's probably what it is that he had. Now, there's also a remote possibility that maybe he didn't have a MAISONNEUVE fracture, and maybe he just had a twist of his knee and he ended up with some kind of a meniscal injury. So obviously, when he gets to the hospital, we're gonna do a closed reduction. So that means we're gonna give him some sedation, put him under, and give him something for pain, and then we are going to pull on the ankle, put it back into its anatomic position. So in this case, I'm assuming that he had some kind of oblique fracture of the fibula. And for that, we would do an open reduction and internal fixation with plate hardware. Now, obviously, because I think that there was also a dislocation and potentially an injury to the membrane or the structures in between the two bones, then he's also gonna need some kind of fixation to close up that space between the fibula and the tibia distally, or at the end of those bones. And that may mean a syndesmosis screw across both bones. I'll show that here. Or if the surgeon is familiar with newer techniques, that may mean a syndesmotic tightrope, which I'll also show right here. For those of you who are paying attention, you'll want to know, what about the MAISONNEUVE fracture up at the top? Because the fibula only takes about 5% of the weight that is transmitted through the lower leg, we really don't have to do anything for that fracture at the level of the proximal fibula if it is not significantly displaced. We'll fix the fracture at the far end, we'll leave the fracture at the top end to heal on its own, and that'll be just fine. A lot of you are going like, what the hell did he say and what is he talking about? So let me give you the Coles Notes version. We're gonna take ALLEN HURNS to the hospital. At the hospital, we're gonna take x-rays. Once we figured out what the fracture pattern looks like, we're gonna take him to the operating room. We're gonna put him to sleep, pull on the ankle, put it back into position. To hold it in place, we're gonna make an incision.
I'm not sure which one to cut here.
Put a plate and screws at the far end, and at the top end, we generally don't need to do anything for that. Once we're done, we're gonna close up the incision, put him in a cast, Bob's your uncle, done. Wait for 6 to 8 weeks for it to heal, and then we start rehab. Do you got it? Did you get it? You understand? Simple. Crack it into place, put him in a cast. So after this is all healed, which usually is gonna take about 6 to 8 weeks, then we have to do physiotherapy. Because he's been immobilized for most of that time, we have to regain the lost range of motion in his ankle. And then they can restore first their baseline strength, which allows them to do normal activities such as walking. Then I will allow them to do additional strengthening to prepare them for a return to sport. For the typical high-level athlete, his return to sport activity may take anywhere from 4 to 6 months before he is at a level which is relatively close to what he was before. But it may take even longer than that. And for the person who is not the professional athlete, who doesn't have all day to do rehabilitation, it may take longer. It may take up to a year. Although this was a really gruesome looking injury, I do think that this is something that he can recover from, and I think that he'll be able to get back on the field next year. Today we've gone in depth on ALLEN HURNS injury. So if you're new to the channel, be sure to subscribe, hit the notification bell. If you're a member of the returning intern army,
Reasons one, their leading scorer, Carmelo Anthony, 27+.
give us a like, share it with a friend. And as always, that's been a word from Dr. Chris, not your everyday ortho.